A warm welcome once again to our session this morning. We have a Rhinology virtual ward round this morning. So very welcome to all our participants, whether it's from South Africa, from our continent of Africa, or outside the continent. We have two interesting case presentations today from registrars at the University of Cape Town. Just some house rules before we begin. If everyone can kindly just register on the chat function using your position. For example, registrar, consultant, your institution, and your country. Secondly, if you can just keep your microphones on mute throughout the course of the presentation. And if you have a question, please feel free to type it on the chat function, or if you want to ask it personally, just raise your hand using the function on your tab, and I will give you the cue to go ahead. But once again, a warm welcome, and thank you to our presenters. Dr. Raphael Mlauzi is our first presenter this morning, who's a registrar at the University of Cape Town. Dr. Mlauzi, please, I'll hand over to you.
Thank you, Tasia. Good morning, everyone. Good morning, everyone. My name is Raphael. Our first case is, before I present the first case, I have no disclosures to make, and I obtained the consent from the patient, oral consent. My presentation is referenced mostly to Scott Brown, the 8th edition, and Cummings, the 5th edition, and the other references and images are referenced as quoted in the slides. So our patient was a 33-year-old female that we saw this year, who was asthmatic and hypertensive, well controlled. She was COVID negative. She presented to us with a chronic headache, which was mostly frontal, and parietal. She also had diplopia and decreased vision of the right eye. Also had decreased hearing in the right eye, but she didn't have any facial paresthesia. On examination, she was well looking with a Glasgow Coma scale of 15. She had a right cranial nerve 6th palsy and reduced movement of the right occipitofrontalis muscle. On otoscopy, she had normal bilateral tympanic membranes, which were mobile. Rhina was negative on both sides, and Weber was central. There was no protosis, and the rest of the cranial nerves were normal. We referred her for ophthalmology review, and the visual acuity on the right eye was 6/9, and on the left was 6/6, with a normal fundoscopy. We did an audiogram on her, which showed a moderate to severe mixed hearing loss of the right ear. And on the left ear, she had mild to moderate, also mixed hearing loss. It was a fairly good test reliability audiogram. So we did an axial CT scan on her, which showed a destructive bony erosion of the right petrous apex, as we can see on the image shown here. We also did a CT angio to assess the vessels, and they showed a poor opacification of the right cavernous sinus and the internal jugular vein, and also mild irregularity of the petrous portion of the right internal carotid artery. However, on the internal carotid artery, there was no dissection, there was no pseudoaneurysm, and there was no contrast extravasation. We proceeded to do an MRI, which showed, as you can see on the image there, it showed a hyperintense lesion in the right petrous apex. This is a T2 weighted image. So we decided to take her to theater, and we did a transnasal transsphenoidal endoscopic biopsy and decompression of this lesion. The procedure was, we raised a left mucoperichondrial flap and did a posterior septectomy for access, and the sphenoid rostrum was drilled away, and so was the sphenoid intersinus septum. And the bone of the right lateral sphenoid wall was thinned with a burr, and the mass was noted to be in the lateral wall of the sphenoid sinus. It was noted to be pulsatile on visual inspection, just inferior to the optical carotid recess. We aspirated with a spinal needle to make sure that there was no blood or anything associated with the mass. So the mass lesion was decompressed, biopsied, and suctioned until it was dry. It was a mucoid granulomatous lesion, which was then sent for histology. There was no evidence of a CSF leak. We achieved hemostasis, and the left septal flap was repositioned and sutured to septum with the 4O vicryl. Next, that powder was applied for hemostasis, and an uninflated rapid rhino also was applied. Postoperatively, she didn't have any complications. Her course was regular. We later on obtained histology. These are the technical details on it, but the conclusion was the pathological diagnosis was right Petrous apex biopsy showed features highly suggestive of a chordoma. And the patient was subsequently referred to oncology for radiotherapy. So my talk today, I'm going to give an overview of Petrous apex lesions. This is a huge topic, and it's barely possible to cover it in the 20 or 30 minutes that I have. So I've chosen to show those areas that I thought would be of interest. So Petrous apex lesions are rare lesions, and they are located in a complex anatomical location. And because of that, they are challenging to access. And there are also critical structures which are in close relation, as we shall see in the next slide. And the lesions and their management are associated with a high morbidity and mortality. Now, this is an axial view of the region of the Petrous apex showing the associated close important structures. As you can see, there's the cochlea, and there's the intratemporal internal carotid artery here. And you can see this is the trigeminal nerve and these three divisions, V1, V2, and V3. You can see there this sphenoid sinus and with the cavernous sinus next to it. And then posteriorly, you can see the cerebellum and the cerebellopontine angle there. So as you can see, there are a lot of important structures which are associated with the Petrous apex, and this causes morbidity and mortality of the lesions themselves and post-operatively. On the right side is a cadaver dissection of the Petrous apex region. So as you can see, this is the sphenoid, and the Petrous apex is just next to it there. And then on the lateral side, we can see the eustachian tube, and we can see the cerebellopontine angle there. The carotid artery is there on the anterior part. Now, the differentials of Petrous apex lesions include infections which can be Petrous appendicitis, TB, osteitis, or osteomyelitis as part of scalp-based osteomyelitis. We can also get cysts, which can be cholesterol granulomas or epidermoid cysts or mucosal cysts. Also anatomical variants because of a defect in the superior wall of the Petrous apex, and also effusions. And we can also get neoplasms, which include chordomas, chondrosarcoma, meningioma, schwannoma, and glomus tumors. I will not talk about schwannomas and glomus tumors because they are a big topic on their own and they've been discussed before. You can also get metastatic tumors, like mostly from the bronchial carcinoma and renal cell carcinoma. Imaging forms a big part of the management of these tumors. This is usually combined CT and MRI. The CT scan is used to show bone destruction versus a well-defined expansion. So this will help in differentiating between a benign lesion, which will be well-defined expansion, and the malignant lesion, which will show a bone destruction. MRI, it can either be T1 sequence or T2 or invasion recovery sequence or diffusion-weighted image. The diffusion-weighted image being most useful to distinguish cholesteatoma from other lesions. Now, with the combination of the CT and MRI, with the latest technology, one can actually make a very accurate diagnosis. And sometimes with that diagnosis, it might not even be necessary to actually do a biopsy of the lesion to confirm it, though sometimes it is necessary to do a biopsy. So I'll go through some of these lesions. The first one is the Petrous appendicitis and osteitis. This is infection of the Petrous apex, and this usually starts from the middle ear. However, with the advent of use of antibiotics, it is rare to actually see the whole triad of Kratochvil syndrome, which is a middle ear infection associated with a deep-seated orbital or retroorbital pain and lateral rectus palsy. So one can see one or two of these, but it is rare to actually see it in full in full as it is. So these are the CT images. They show a hyper-intense signal on T2 weighted image. As you can see, the T1 weighted image, which is A here, it doesn't show it so well as the one on the right. Cholesterol cysts usually present with a fluctuating conductive hearing loss and affect eustachian tube function. We saw the eustachian tube just lateral to the petrous apex. And it has a hyper-intense appearance on T1 and T2 weighted images. Epidermoid cysts, these develop over a long period of time. And because of that, they cause lateral displacement of the internal carotid artery and a profound sensorineural hearing loss. The hallmark of this lesion is a cranial nerve 7 palsy and facial weakness. These give a high signal on a T2 weighted image, as we see on the right side, and they've got a low signal on T1 weighted images. The CT scan shows a well-demarcated destruction of the petrous apex. And as I've said, this is a slow-growing benign lesion. There is no bone erosion. Mucosal cysts, this is thought to be caused by hemorrhage into the marrow spaces, and it is found in well-pneumatized temporal bones, and they also develop over a long period of time. And because of that, they also cause lateral displacement of the internal carotid artery. And they will present with a trigeminal neuralgia, generalized headache, and otalgia. So they are hyper-intense on both T1 and T2 weighted images, as we can see. But then this also depends on the mucosal. Also, it depends on because they vary in terms of the components, the protein component and the fluid component. So because of that, you can get a varied appearance on either T1 or T2 images. Anatomical variants, this can either be defects in the superior surface of the petrous apex, which leads to meninges prolapsing into the apex to form a meningocele, or it can be because of asymmetric pneumatization, or it could be because of an effusion, the so-called live-alone lesions. So these are images that show the petrous apex effusion. It's a T1 weighted image, and on the left side, that is A, and then B, it's a T2 weighted image. As you can see, it lights up nicely compared to the T1 weighted image. And on the far right side is the CT scan. Meningiomas are the most common intracranial tumor. They develop around venous sinuses, and they do little harm to surrounding structures. They have a slow growth, and 90% of them are benign. So they've got a characteristic appearance on MRI, which, as you can see, as the arrow there shows, this is called a dural tail, which is an enhancing tumor extending away from the mass, from the main mass along the dura. This is what our patient had, a chordoma. This develops from a notochord remnants, and they are mostly found in the axial skeleton. They are mostly in the midline, like in the coccyx, for example. But then, like when they are found in the petrous apex, they are thought to have been spread from the midline. They are mostly common in the fourth decade. Both sexes are affected equally. They tend to stretch the dura and exert pressure on the cranial nerves, and they are locally malignant tumors. They present with headache, which our patient had, and facial pain. They present with a visual disturbance and diplopia. They have trigeminal deficits or neuralgia and hearing loss. And they can also present with voice disturbance and swallowing problems. This is the image of our patient showing a hyperintensity on the T2 weighted image. And it's also described as having honeycomb structure on gadolinium enhanced images. A chondrosarcoma develops from cartilaginous remnants. Most of these tumors are low grade, and they tend to break through the cortex of the temporal bone and extending to the cerebellopontine angle, the neck, the middle cranial fossa, and the cavernous sinus. And they are hyper-intense on T2 weighted images. And the imaging characteristic that is usually used for them is that they show chondroid matrix calcification, as we can see on the image there. In terms of the treatment, management of these lesions depends on tumor factors, patient factors, and institutional factors. There are 4 ways in which they can be managed. either watchful waiting, drainage, or resection, and chemoradiation. So in terms of the tumor factors, it depends on the tumor itself, whether it's a slow-growing tumor, whether it's a benign tumor or malignant tumor. And the patient factors which affect this are the age of the patient, the life expectancy, that is the time at which you diagnose them, the general health of the patient, the severity of the symptoms, and cochlear function. Institutional factors would include factors like expertise of the surgeon and the equipment that is available at our institute. So in terms of watchful waiting, this would be appropriate, for example, in an elderly asymptomatic patient. And because surgical intervention doesn't normally resolve the neurological deficits, patients with sensorineural hearing loss and tinnitus only, an argument can be made for them to actually be watched and not operated on, and they can be monitored by serial scans. Drainage is mostly done for a majority of the cholesterol cysts, and this can be transsphenoidal or transmastoidal. And what I'll talk about a bit in detail is a resection, which can be by a subtotal petrosectomy, or it can be transsphenoidal, or it can be done through a fish type B approach or a medial cranial fossa approach. And finally, a chemo or radiation therapy involves use of stereotactic radiotherapy or intensity immune regulated therapy or proton beam therapy. And also it can be used for palliation. So most of these surgical procedures will involve the sphenoid. So the important thing is assessing the sphenoid sinus. So assessing it can either be done by endoscopic approaches or by open procedures. So in terms of endoscopic procedures, what is available and described is a direct one of them is a direct transnasal approach, which is through one nostril. And if there's any difficulty in assessing the sphenoid sinus, for example, if there's a deviated nasal septum, a septoplasty can be done for access, and the superior tapinate may or may not need to be removed, and the posterior part of the medial tapinate may or may not also be removed. The second described type of endoscopic approach is ethmoidectomy, which involves doing an asunectomy, ethmoid bular resection, and resection for the rest of the ethmoid cells. If the onote, and when one is doing ethmoidectomy, one is to note if the onote cell is present and its relation to the optic nerve and the internal carotid artery. So the anterior ethmoidal artery is identified, which lies anterior to the sphenoid sinus wall before entrance into the sphenoid sinus. Transeptal access, as you can see on the diagram, it's mainly done for midline access through to the sphenoid sinus through the nasal septum, and it is useful for midline lesions. Various open surgical approaches have been described. I'm not going to go into detail about them, but I'll just go through them. They are either transseptal sphenoid or transethmoidal sphenoid. I got this list from a Cummings, or a lateral rhinotomy after you opening up the soft tissue that is followed by a maxillary antrostomy, or there's a transantral approach, also known as a transantrosphenoidal approach. One can also do a midfacial declaving, which is done through incisions in the intranasal and sublabial region. Lofort 1 osteotomy or transpalatal approach, an extended maxillotomy, midfacial split, intratemporal fossa, and a facial translocation. Autological approaches have also been described. These take advantage of air cell tracts. Now, these air cell tracts can be above the otic capsule, and if one follows the superior ones, those that are superior to the optic capsule, you can do through a medial fossa approach, or through the superior semicircular canal, through the attic, or through the root of the zygomatic arch. If one follows the air cell tracts that are below the otic capsule, one can approach the Petrous apex through an infralabyrinthine approach or through the infracochlear approach. And if one uses the cells that are anterior to the optic capsule, you can go in a triangle which is between the cochlea, the carotid artery, and the medial fossa dura. So the fish type B approach, the essence of it is the facial nerve is rerouted anteriorly, and the horizontal intrapetrous carotid artery is exposed. The clinoid fossa is removed, and there's a division of the medial meningeal artery and the division of the V3. All this after a subtotal petrosectomy is done. and then you can get access to the Petrous apex. Thank you very much.
For your patience, I've got a interesting case presentation. Just as a introduction, it's an interesting case, but there's a lot of red herrings in the presentation that I'm not going to dwell on, and just jump to the meat of the matter. There we are. So Mr. ML is a 47-year-old gentleman whose presenting complaint was a year's history of a blocked nose, right slightly worse than the left, intermittent epistaxis bilaterally, for which he'd had no treatment, medical or surgical, and no rhinorrhea or hyposmia. Severe headaches that were not typical of migraines or any sort of typical headache syndrome. But then also a number of other symptoms not related to rhinology, being oscillopsia and diplopia. The diplopia was a bit of a strange one in that he said instead of getting 2 images, he got more than 2 images at some times, which clearly is not sort of physiologically possible. So that already alerted us to the possibility of some other functional issues possibly going on. He had paresthesias of the top and bottom lip in the midline, spasms of the left top lip, fluctuating hearing loss and disequilibrium, and then globus pharyngeus and intermittent dysphagia for solids, but no odynophagia. About a year previously, he had chronic rhinosinusitis without nasal polyps, for which we did a sinus surgery, including a bilateral middle meatal antrostomy, reduction of concha bullosa of the middle turbinates, and a bilateral frontosphenoethmoidectomy. So we were thinking at the time that the concha bullosas and the sort of anatomical abnormalities were contributing, obviously, to the sinusitis picture then. But so it appeared to be that his previous surgery hadn't been quite adequate. He also has a background history of monostotic fibrous dysplasia, diagnosed on a CT scan at another hospital. G6PD deficiency he was known with from childhood and was using dietary measures to control that. And a sensory neuropathy that he was well known with anesthetic patches on the sides of his thighs, for which he was on medical treatment. Socially, he owns a small restaurant and he stopped smoking but still vapes. On examination, obviously with the fibrous dysplasia, and some strange presenting complaints, we were considering if it wasn't a presentation of McCune-Albright syndrome, but there was no features of Cushing syndrome, no cafe au lait spots. Flexible nasal endoscopy showed very little mucopus in the osteomeatal complexes bilaterally, and otherwise the septum was central. There was no residual concha bullosa. Everything else seemed more or less structurally normal. And cranial nerves, central nervous system, basically he had some clear cerebellar signs with hypermetria and a hypometria of eye movements and finger nose testing. He had reduced visual acuity, 6 out of 18 bilaterally, confirmed by the ophthalmologists, but normal visual fields and normal eye movements. So specifically normal eye movements, despite him complaining of intermittent diplopia. He had that anesthetic patch on both thighs anterolaterally, consistent with his sensory neuropathy. I was going to show the CT scan, but despite our best efforts and the efforts of Gerrit, who's normally our IT whiz, we weren't able to get the CT scan to load onto the PowerPoint. But basically, it was a fairly typical sort of radiological picture of monostotic fibrous dysplasia involving the clivus and the left temporal bone, crossing the suture line as it characteristically does, But then there was one slight atypical feature in that it was expanding on the inner table of the bone to compress on the cerebellum, about a 1 centimeter expansion into the cerebellar area. So that certainly accounts for the cerebellar signs, and the fibrous dysplasia of the clivus and around the sphenoid sinus area would have accounted, I think, for the trigeminal symptoms of the paresthesia on the top and bottom lip. But a lot of the other cranial nerve signs really can't be accounted for. So because it was a slightly abnormal case presentation, we took him for a revision fez surgery, basically, but only did a bilateral middle metal antrostomy to get a sample of that pus for MCS, and then a transforaminal biopsy of the bone from the clivus. The results of that are not yet confirmed as a final report, but we have a verbal telephonic report confirming fibrous dysplasia. So it was an interesting case, and I thought I would just review some fibro-osseous lesions and not get too much into the details of his multiple other cranial nerve deficits and strange symptoms, because that's getting away from the point. So fibro-osseous lesions are quite a complicated group of lesions. It's an umbrella term classifying a large group of benign lesions, some of which are dysplasias and some are tumors. Many of them have similar histopathology, and the classification schemes are quite confusing and often quite overlapping in the terminologies. The terminologies have also changed on review of the literature, with overlapping groups of disorders. They often lump various disorders together and then split them apart in subsequent classification schemes. So it is a bit confusing. Some of the classification systems group all of the cystic lesions together and tumors together separately, but then that doesn't quite work because some of the tumors are cystic and some of the cysts are actually tumors, so that's not a good classification system. Some fibro-osseous lesions are characteristically craniofacial, and some are skeletal, and some involve the rest of the skeleton, but that's also not a good classification because many of them involve both areas. So in many textbooks, you'll find a good description of, for example, the temporal bone component of fibro-osseous lesions, but ignoring all the other components. So it's a difficult area to read through. And the second sort of, and the last problem in quote marks with the classification system is that the radiological appearance does sometimes evolve as the lesions mature. So for example, they can start off with a lytic lesion that then becomes sclerotic as the disease process continues. So I'm not going to present on all of the fibro-osseous lesions, but just the ones that we commonly see. So fibrous dysplasia and its variants, Paget's disease or osteitis deformans, some of the dysplasias, and ossifying fibromas. So for fibrous dysplasia, first of all, it is a localized arrest in osteoblastic differentiation and maturation of the bone, replacing normal bone with large areas of fibrostroma and immature woven bone. The etiology is an acquired mutation in the GNAS1 alpha gene that may be isolated and sporadic, or it may be a part of some syndromes. It's equally common in men and women, and in terms of the skeletal involvement, it can involve the ribs, long bones, and vertebrae to cause scoliosis. So if there's a skeletal component, the patient should be fairly easy to recognize sort of clinically, with characteristic fingers with widening of the pulp space of the distal tips of the fingers. But importantly, it's not involving all of the fingers because it's a sort of patchy involvement of the bones throughout the body. So you get some fingers that can be involved and some not involved. there can be an obvious scoliosis and pathological fractures in the long bones, for which the patient may have had previous orthopedic surgeries. The minority of the involvement is in the craniofacial bones, and it tends to affect the anterior bones in the head and neck more. So specifically the maxilla, frontal bones, sphenoid, and ethmoid bones, more so than the mandible, and very little involvement of the temporal and occipital bones. The classification is also monostotic versus polyostotic, where the majority is monostotic, obviously involving one bone. But in the case of craniofacial involvement, it can sometimes involve adjacent bones, because the fibrous dysplasia does characteristically cross suture lines. And that would, in the context of craniofacial disease, that would still be called monostotic disease. Polyostotic is multiple bones throughout the body and occurs at an earlier age of onset. And the craniofacial involvement is much more common in polyostotic fibrous dysplasia. So fibrous dysplasia can be a part of different syndromes, can be sort of occurring together with the fibrous dysplasia. So McCune-Albright syndrome is the most well-known one, occurring in polyostotic fibrous dysplasia. They get cafe au lait spots that are typically ipsilateral to the majority of the bone lesions. And so you can see on the picture of the chest, it doesn't cross the midline of the chest. Laterally, it's described as being the characteristic shape of the coast of Maine, which is roughly that sort of shape. McCune-Albright is also associated with hyperfunctioning endocrinopathies, most characteristically Cushing's syndrome, and that does also relate to some of the other symptoms, particularly the bone pain is worse in McCune-Albright syndrome. Secondly, there can be Mazdabroug syndrome, which can occur in monostotic or polyostotic fibrous dysplasia, which is characterized by intramuscular myxomas. So the symptoms of fibrous dysplasia can be quite variable, ranging from just having bone pain and barely noticeable sort of small bony expansile lesions to having proptosis and dystopia, even a mucocele, as you can see. I don't know if the cursor is working, but a mucocele in this lady's frontoethmoid area. Misaligned and loose teeth if it involves the jaws. Obvious craniofacial asymmetry in later stages. And then if it's compressing the cranial nerve foramina, then reduced visual acuity and hearing loss. So on imaging, fibrous dysplasia is characteristically a ground glass appearance, as you see in the top right picture. But you can also get a less common variant called the pagetoid fibrous dysplasia, because of its similarity to the radiological findings of Paget's disease, where you get mixed areas of lucencies and sclerosis in one lesion. Fibrous dysplasia does tend to cross the suture lines, like I said. The margin is poorly defined, as you can see on the periphery of some of the lesions. And it tends to widen the diploic space, but displacing the outer table much more so than the inner table, which again will be contrasted to Paget's disease. With more advanced disease, it can extend into the orbits, sinuses, and cranial nerve foramina. The natural history of the disease from its onset in childhood or adolescence is thankfully that it often burns out as the child reaches puberty and skeletal maturity is reached. But obviously, in many cases, it doesn't and goes on to adulthood. In terms of diagnosis, the clinical diagnosis with imaging is useful, but the imaging is not very specific, and a biopsy is often needed for definitive diagnosis. If facilities permit, then peripheral blood can be taken for PCR to identify that specific gene mutation. Complications that occur, like I said, are the pathological fractures. You can get cystic degeneration and malignant transformation. The malignant transformation is more commonly occurring in polyostotic fibrous dysplasia, and particularly following radiotherapy, which is now an obsolete modality of treatment for the disease. the malignancy would then be most commonly to osteosarcoma, much more so than fibrosarcoma or chondrosarcoma. So if you take a biopsy, the characteristic appearance is this Chinese letter or Hebrew letter shape of the trabeculae, contrasted on the right and left side of the picture. So in terms of management, many cases of fibrous dysplasia are completely incidental. And if it is such and the symptoms are mild, then watching and waiting is completely appropriate. If the airway is compromised or the vision is compromised, then one can consider surgery. But with the controversies being between early versus late intervention, do you intervene early to try and save someone's vision or improve the airway at the risk of knowing that the disease is likely to continue in later stages, despite the surgery, or do you go for a later intervention when they have very little to lose? Secondly, do you go for a minimal versus radical resection? Do you just try and debulk a little bit and decompress the nerves a little bit, or do you try and radically resect the entire lesion? Obviously, if it's in the early stages and accessible. If you're going to do a radical resection, would you do a reconstruction or would you not? So there's many controversies, and it has to basically be an individualized decision on each patient. In terms of medical treatment is available, specifically to relieve bone pain and slow the progression of disease. So bisphosphonates that were prototype used in osteoporosis, alendronate and primidronate are used. They are known to inhibit the osteoclasts, so they reduce the lytic process of the disease and can relieve bone pain. Calcium and vitamin D supplementation has been shown to slow the bone resorption. And then new on the treatment horizon is biologic treatment using monoclonal antibodies to inhibit interleukin-6, which is involved in driving the osteoclastic process. For neuropathic pain, pregabalin is well known to help with neuropathic pain, and our patient was on that already. Like I said, the radiotherapy is now a completely obsolete treatment modality because, first of all, it is now known to be completely ineffective and also causes a risk of malignant transformation. Then, so we get reparative giant cell granulomas as well, also known as cherubism, which was thought to be a subtype of fibrous dysplasia, but is now known actually to not be that, and it's changed its classification from one of the former classifications so it's now basically a familial bone dysplasia occurring in men more than women. It can be isolated with autosomal dominant inheritance, or it can be associated with Noonan's syndrome or neurofibromatosis type 1. The patients get characteristic cherub faces, named after the Renaissance pictures of cherubs, with these puffy round cheeks from expansile lesions in the mandible and maxilla. But the lesions are limited to the mandible and maxilla. The maxillary involvement can cause a compression of the orbital floor, lifting up the orbits laterally, causing an upward gaze appearance. And the involvement in the mandible and maxilla can cause loss of primary teeth in childhood, and it can prevent eruption of the permanent teeth. So chubby cheeks, upward slanting eyes, and edentulous is kind of like a baby cherub. In terms of imaging, you get these bilateral multiloculated radiolucencies with expanded cortices. Thankfully, the lesion is one of the few fibro-osseous lesions that often resolves as the child reaches puberty. So if the disease is mild, one really can just watch and wait until puberty, hoping that in puberty it'll completely resolve. If it's more severe and cosmetically and functionally impairing the patient. Or if it doesn't resolve at puberty, then orthodontic procedures and surgical excision of the bone lesions would be the treatment, and often needing bone grafts. Then we got Paget's disease of bone, which we must specify the of bone because Dr. Paget in 1887 actually described a few different diseases. But Paget's disease of the bone, he described as osteitis deformans, which we now know to be a misnomer because it's not actually an osteitis. It's more of an osseous, it's closer to being an osseous dysplasia. So it occurs from excessive breakdown of bones throughout the entire skeleton and disorganized remodeling, resulting in bone pain, bone expansion, pathological fractures, and cranial nerve neuropathies. It tends to occur in elderly patients, men a little bit more commonly than women, but it's actually quite common. It's the second commonest disorder of bony metabolism after osteoporosis in the elderly. There's a clear geographical distribution of Paget's, being particularly common in the United Kingdom, Western Europe, Australia, and New Zealand, and quite uncommon in Africa, Asia, and the North and South Americas. The etiology is debatable, but mutations have been identified in the RANKL gene, which encodes P62 and osteoprotogerin, which are involved in regulating the osteoclasts, and mutations in genes encoding nuclear factor kappa beta have been identified, which is involved in regulating ubiquitin, the tiny protein that is involved in multiple processes throughout the entire body. Also, osteoclasts of patients with Paget's disease have been shown to contain viral particles of measles, RSV, and canine distemper virus. But as with the measles virus in bone of otosclerosis, there's no causality that's been demonstrated. It's just a hypothesis. So in terms of stages, you get 3 stages that the disease typically progresses through, from an early or incipient active stage characterized by excessive osteoclastic activity, resulting in bone resorption and the lytic lesions, coin-shaped lytic lesions. Then it progresses to an intermediate stage with mixed osteoclastic and osteoblastic activity, and then a late or inactive stage where the disease can burn out with osteoblastic activity and bone deposition. But importantly, it's in a disorganized manner, and excessive amounts of fibrous tissue and blood vessels are laid down in the marrow spaces. Some classifications do say that there's actually 4 stages, with the 4th stage being malignant transformation. But I think that's a bit pessimistic to assume that everyone's going to reach a 4th stage. So it would be nice to just have 3 stages. Clinically, the majority of patients are actually diagnosed incidentally on imaging for other reasons, but they can present also with localized bone pain, tenderness, and warmth, obviously because of the excessive amount of blood vessels in the lesion. So warmth over the area of the bony expansion. Cranial nerve neuropathies if the cranial nerve foramina are compressed, with sensorineural hearing loss being most common. Loose teeth, and then progressive skeletal deformities. Dr. Paget, in his era in the 1800s, described an increasing hat size, progressively increasing, was one of the early symptoms of his cohort of patients with Paget's. But bowing of the long bones, kyphosis, and vertebral collapse. And then you can see in the bottom right-hand picture, this expansile lesion of the bone of the skull, forming irregular bones of the skull and face. If it occurs around joints, you can get reduced range of movement of the joints that can cripple the patient quite badly as well. So in early stages, we said you get that coin-shaped lytic lesions. In craniofacial bones, the expansile lesions can have a ground glass trabecular pattern. Calvarial bones have that widened diploic space, but with the inner table being more expanded than the outer table. And late stages, they get that cotton wool appearance of diffuse patches of sclerosis around the bones. In the vertebrae, you get that characteristic ivory vertebra, which is obviously prone to vertebral collapse because it's not very strong. In terms of investigations, the serum ALP is elevated, but the calcium and phosphate levels are actually normal. You can do urinary levels for hydroxyproline, which are typically elevated, and a skeletal survey with technetium-99 scintigraphy is obviously highly sensitive for the active phases of disease, but much less so for the inactive phases. And obviously it's not specific, it can be from anything, and specifically it can also be, it wouldn't be of any use in identifying malignant transformation. Histopathology shows a characteristic increased bone turnover with the cells involved in that, and trabecular bone laid down in a haphazard mosaic pattern, like you can see in the picture, looking like mosaics fitting together nicely. In terms of complications, the sensorineural hearing loss from compression of the 8th nerve foramina, and conductive hearing loss from involvement of fixation of the ossicular chain would be the two reasons that they would come to ENT. But they may also have pathological fractures, osteoarthritis because of abnormal loading of the skeleton, and skeletal misalignment, giant cell tumors characterized by multiloculated radiolucencies, and then malignant transformation to sarcomas, like we said, being much more common to produce osteosarcomas than fibrosarcoma, chondrosarcoma, or an undifferentiated sarcoma. The malignant transformation tends to occur in elderly patients with advanced disease. It's more common actually in the pelvis and long bones than calvarium, and not very much in other bones that we would see. Medical treatment is very similar to that from fibrous dysplasia, with the bisphosphonates and calcium and vitamin D, and biologics to inhibit interleukin-6, pregabalin for neuropathic pain, and then chalcitonin is calcitonin that has been harvested from salmon, which has been used to help slow the bony progression of disease. And then obviously exercise can help to maintain bone density and also to lose weight to reduce the load on the malaligned skeleton. Then there is also a variant of Paget's called juvenile Paget's disease that characteristically occurs in patients under the age of 15. It's also known as idiopathic hyperphosphatemia. So in saying so, there is obviously blood tests that can support the diagnosis of juvenile Paget's disease. It's inherited with the autosomal recessive inheritance pattern. And in young children, you get this hair-on-end appearance on a skull X-ray, severe bowing of the long bones of the limbs, and in some cases, if it doesn't burn out by puberty, they can get gross craniofacial cosmetic deformities. So then to move on to the cemento-osseous dysplasia is actually the commonest fibro-osseous lesion in the jaws. It's confined to the teeth-bearing areas of the alveolar processes of mandible and maxilla, so therefore is thought to be odontogenic in origin, although there are some questions of that, which we'll expand on later. It occurs in middle-aged people, African and Asian more common than Caucasian, and women more often than men. It can occur on its own, or it can be associated with simple bone cysts or with Paget's disease, just to confuse the issue. So you can have a clear diagnosis of Paget's, but that it can still be associated with the cemento-osseous dysplasia as well. And the classification is according to the area of involvement of the mandible and maxilla. So periapical would be around the around the apices of the teeth, and focal and florid according to the extent of involvement of the mandible and maxilla. Focal usually at the posterior mandible, often at sites of previous dental extraction, and often a completely incidental finding. Florid cemento-osseous dysplasia is involving 2 or more quadrants, often all of the quadrants of mandible and maxilla, And complications is that these lesions can become secondarily infected with oral bacteria to cause diffuse sclerosing osteomyelitis, which is one of the other differentials of a fibro-osseous lesion that I'm not going to go into discussing because there are so many other differentials that one could discuss if one had much more time. The important thing about cemento-osseous dysplasia is that there's no risk of malignant transformation. So if the finding is completely incidental and the imaging is typical, then no further investigation is needed at all. But if the patient presents with dental complications, then a dental extraction is certainly warranted and follow-up after that. Ossifying fibroma is the last group of lesions that I'll discuss. So in some of the previous classifications, they separated ossifying fibroma and cementifying fibroma. In other classifications, they lumped them together into cemento-ossifying fibromas, COF. So it just depends on the classification, but basically it depends. Both diseases can be thought to be two ends of a spectrum, depending on simply the relative amount of cementum or ossified bone in the lesion. And in most cases, some of both are present. But for simplicity's sake, many people just include it under the broad umbrella term of ossifying fibroma in general. It's a benign tumor occurring typically in middle-aged adults, men and women equally. It may also occur in hyperparathyroidism, which would then be associated with familial parathyroid adenomas, renal cysts, and Wilms tumors. So one should always just keep that in the back of the mind as something to look out for because of the significant impact of the tumors. So they usually present as painless, slow-growing tumors involving the mandible more so than the maxilla, but the buccal and lingual surfaces may be involved. The mandible is often the premolar area more so than the maxilla, and it may displace the teeth out of the sockets, it may loosen the teeth, and maxillary involvement may expand into the maxillary sinuses. You may have multiple ossifying fibromas in one jaw. So that would then obviously mimic polyostotic fibrous dysplasia, or it may mimic florid cemento-osseous dysplasia as well. So there's a lot of overlap and similarity of many of these lesions. Radiologically, they are usually a round or oval shape with well-defined margins, usually have a thin intact cortex like on the right-hand side picture. They usually initially are radiolucent, but as the lesion matures, can become radio-opaque. Histopathology is often quite variable and non-specific and may be indistinguishable from fibrous dysplasia. So many pathologists will not give a clear report of a fibrous dysplasia and will rather require input from the radiologist and the clinical picture to confirm the diagnosis. Ossifying fibroma is one of the many of these fibro-osseous lesions that may have cymomatoid bodies and cymomatoid ossicles specifically, as you can see in the picture on the bottom left. So lamellated basophilic collections in the bone. Treatment is by complete excision, and if the excision is complete, it is a benign tumor, it very seldom recurs. Obviously, depending on the extent of the excision, one may require plating of the mandible or maxilla as well. There's also two other variants. The one is a juvenile ossifying fibroma, which is common in children less than 15 years of age, boys and girls equally affected, occurring in the mandible and maxilla, but specifically also in the bones outside of the jaws. Hence the query as to whether it really is odontogenic. because, or is this perhaps a completely different disease process? But the extranethic bones can specifically be the periorbital bones, frontal ethmoid bone, and calvarium. So that may obviously then present to a rhinology clinic with a rapid but completely painless growth of the bony lesion. In the maxilla and sinuses, the patient may present with blocked nose and epistaxis, and if it's involving the orbit, the patient may present with ptosis, proptosis, ophthalmoplegia, reduced visual acuity, and papilledema on examination. The juvenile ossifying fibromas are a bit different as well, in that they may invade surrounding bone. So they may then recur after an excision. One must keep that in mind. And the histopathology also includes symptomatoid calcifications. The last variant of ossifying fibroma and the last of these fibro-osseous lesions is a rare subtype of ossifying fibroma called a gigantiform cementoma that in itself has jumped its place in the classification from fitting under various different headings, and but it's now thought to be a subtype of ossifying fibroma. It occurs in young children with autosomal dominant inheritance, and it produces these massive, giant, multifocal ossifying fibromas in the mandible and maxilla only. Histopathology, again, also shows these symptomatoid calcifications, but obviously it is, as you can see, quite disfiguring. So just to summarize, these fibro-osseous lesions are quite complicated just to get your head around the classification systems and where each one fits in, to try and remember the sort of characteristic features and to advise a patient accordingly. But there's a lot of literature on the topic. In terms of references, there's a very good and very well written review of craniofacial benign fibro-osseous lesions, illustrated in red there. Then I drew reference from 4 systematic reviews. There seem to only be 4 systematic reviews in the literature on fibrous dysplasia, ossifying fibroma, and cemento-osseous dysplasia, both the florid and focal types, all written by one maxillofacial surgeon. And then obviously also references from Scott Brown and 2 other publications. Thank you very much.
Great, thank you very much, Simon. That was a fantastic overview for a very, very complicated topic. I see no questions on the chat function, and I suppose if anyone has any questions or comments, please just use the chat function or raise your hand function, and I can provide you the opportunity. Professor Fagan, any comments from your side on our 2 presentations and quite complex 2 presentations that we've had today?
Thank you very much. Both very comprehensive. I've got no comments or contributions to make.
Thanks, Prof. I see one of the past fellows for Professor Liber, Dr. Kafui Serorio from Ghana, has joined us as well. Kafui, any comments from your side on things that are quite rare but very relevant to our practice?
I must say this ossifying fibromas of fibro-osseous rare as we think. From the beginning of the year till now, we've seen quite a number of all varying presentations, with very varying presentations here. And some have been quite easy to completely excise, where you find that they have what looks like a pseudo capsule and you're able to go all around to take it out. But the most difficult ones are those that sometimes would extend very superiorly to the frontal sinus, where you cannot, and then in the frontal sinus and then a bit lateral. Those ones appear to be the most challenging ones, that resecting them by a complete endoscopic approach becomes quite a challenge. But otherwise, I think they are quite common. This year alone, I'm sure we've done more than We've done more than 7 or 8 cases of these fibro-osseous lesions endoscopically. Thank you.
Thanks. Just a follow-up question on that. So do you normally have, Kafui, a multidisciplinary kind of meeting to decide on what is the best next? And how do you sort of make your decision on the management for these patients? Just to sort of give us an overview about what your experience there is like.
So what happens is, depending on the site, most that I've dealt with are either those in the paranasal sinuses. Yeah, and what we've had is we usually would consult the maxillofacial. Sometimes we have referrals from their end coming to our end, and then we sort of sit and discuss before we proceed. And in a few cases where you would need maybe a mini plate or orbital floor reconstruction, then we involve them. Otherwise, if it's a straightforward case involving the ethmoids, the sphenoids, and then the frontal, usually we will go alone. The neurosurgeons we work closely with, and in some of the cases, they have rather sent down to us, or we've done it as a joint case on the neurosurgery list.
Okay, very, very interesting indeed. And any comments on the medical treatment that Dr. Honnett had commented on, palidronate and calcitonin supplements, and any comments on those?
I haven't had any experience with any of those yet, and I plan to contact Simon after the meeting to get some of his references, though I'll look out for some myself and see to what extent that helps. But that comes as a very welcome information to some of the very difficult ones that we've had to manage with, especially with those in the sphenoid going a bit intracranial, where complete excision is inachievable.
Great. Thank you very much, Kafui, for your comments.
I think there is quite good evidence, Kafui, of the bisphosphonates in relieving bone pain, and certainly it's very widely used and very well regarded to be safe in the context of osteoporosis. So there's a lot of literature on the use and dosing regimens, and in the context of these lesions, there's a lot of evidence to say that it slows the bony progression and reduces the bone pain.
Thanks so much.